Good afternoon. My name is Ruben Azocar, and I will be chatting with you today about trauma in the elderly. I would like to thank the organizers of the conference for the invitation to speak about this very important topic. In terms of disclosures, I have no financial disclosures, but I'd like to make everybody aware of the Society for the Advancement of Geriatric Anesthesia, an organization where I'm a past president. And if you'd like to learn more about the organization, you have both our website information and our Twitter information at the bottom of the slide. What are the objectives of this lecture? So I'd like to go over and discuss the impact of the geriatric population on trauma services and in healthcare in general. We'd like to review the determinants of outcomes in the older adult trauma patient, and also discuss strategies to minimize complications and improve outcomes in trauma patients. As many of you know, we're facing a significant growth in the geriatric population. Some of them has been called the Great Tsunami, and it's affecting the whole world. The elderly or those over age of 65 are the growing faster segment of the population, growing almost at a 2% per year versus a 1.2% a year. Between the year 2000 and 2030, the number of older adults will increase from 550 to 973 million. And while in the developing world, we have the highest percent of older adults, in the developing world has the highest number of older adults. It's just a relationship between how fast the natality rates are in difference between the two types of countries. Here in the United States, we started around 2010 when baby boomers started turning 65 years and older at a very fast pace. And from going from about 30% of the population in 2010 that was older than 65, currently we are about 16% of the population is over 65. And that's going to keep on growing until about year 2040, when it's going to plateau around 20% of the population. But at this time right now, the number of older people in the US outnumber the number of children younger than 5-year-old in our country. And it's not only those that are older than 65, but we can see that we're also seeing a spike in those older than 85 years old. And that's not only segment of the population in this regard. We have also those that are hitting 100 years old. It's going to increase by the eightfold by year 2050. So we can see that this is a significant impact on the characteristics of the demographic in the United States, which will have significant impact on healthcare. We all know we have a very high spending percentage of the GDP in this country, more than any other developed country. And if we look closely, at least on this data from 2012, while we were almost the same as other countries on patients between age of 10 and 50 years old, once we hit the 55 to 60-year-old, our per capita healthcare costs increases significantly. And this is known not only by us, but also in the public. Of this article from 2015 and in USA Today on how a small segment of the seniors might be consuming most of the Medicare spending. But what has to be also with trauma is that we are not only living longer, but people all over than 65 years of age and engaging into a more active lifestyle. And some of the issues related to trauma are related to that. And we can see that the New York State trauma registry show an increase in traumatic injuries in patients between 75 and 85 years of age, between 94 and 98. And most recently, the National Trauma Data Bank indicated that traumatic injuries on those older than 65 years old have increased from about 30 to 43% since 2010. This is data from 2016. And this, again, data from 2016, the anticipation was that by the year 2020, about $55 billion will be spent on the treatment of geriatric falls, which is the number one reason of trauma in the older adult. Then we have motor vehicle accidents. It's the number one cause of trauma-related death on those of age 60 to 74. And when you look at those accidents, 80% of the time, the older person is the one who precipitated the event, with about 18% of the times having syncopal episodes to be the reason why this happens. You can also see that they have being struck by another vehicle, so 1 in 5 of pedestrians that are killed or hit by a car, and 1 in 10 of those that are injured are older adults. And it's very important not to forget that elder abuse can also be a reason for this patient to present with trauma injuries. This is related to a vehicle crash, and you can see that we have basically a high incidence of crashes per million miles traveled. That's the blue line. That is very high on teenagers, and then it comes down. But then after age of 64, 65, it climbs up again. And the number of fatalities per 100 million of miles traveled is also higher on the younger population, but then really, really spikes over the age of 65. So it's not only more crashes, but the crashes tend to be fatal on the older patients. So if we think about a little bit about trauma outcomes, and on this paper from 2013 in the clinical geriatric medicine, they look at 170,000 individuals more than 65 years of age suffering unintentional injuries, and about 43,000 of those patients will die of these injuries. And on those patients where trauma victims age 75 and older have the highest mortality rate, with rates that go from 86.1 to almost 300 deaths per 100,000 people injured. It's also similar data from increasing trauma deaths in the United States. The blue lines indicate the number of trauma deaths in year 2000, but you can see that the year by year 2010, the deaths on those over 50, 55 years of age are much higher proportion than it used to be 10 years before that. And we can also say that based on mortality is that older adults, if they have a similar injury than a younger patient, they will have a worse outcome. And Grossman et al. Demonstrated there was a mortality rate increase of about 7% for each year of age older than 65. So there is not only we're not only facing higher rates of trauma in the older adults, but we can also say that the outcomes are not as good as their younger counterparts. And what this means is that these injuries and death will have a huge financial burden on the healthcare system, as I discussed in a prior slide. So what could be determining these outcomes? So we could say, well, there are at least 4 factors. There may be age itself, there may be coexisting disease, could be what's the severity of the injury, that's probably the most self-evident ones. But I would like to make emphasis during this lecture about functional status. So let's talk a little bit about age itself. And this is one of my favorite graphs about geriatrics. And you see, if somebody went in health, your basal organ function remains fairly stable and starts declining as we get older. If you're on a healthy condition. But the problem is that our functional reserve, our capacity to respond to trauma and stress, is decreased as we get older. And this is a very important concept as we discuss this topic a little more in detail in the slides to come. But I would like you to show this, at least for now, these two changes that we are very important. And you can see how at age 65, the muscle mass of this younger individual at the time is much more than the muscle mass of the 63-year-old. In the same way, you can see that we have a lot of more brain tissue on when you are 38 years old and whereas you are 73 years of age. So at least these two, remember this for now as we'll continue talking about the other factors that affect the older adult having trauma. Coexistent disease, so there are many that might influence the incidence and severity of trauma. So you can imagine somebody with osteoporosis or arthritis might be more prone to falls, dementia, confusion, or Parkinson. Can relate that to falls or motor vehicle accidents. Same with vision and hearing problems. Diabetes, depression, heart disease. All those might play. The existence of those diseases might play a role on the possibility of a patient developing or suffering of an acute trauma. So we talk a little bit about age. We talk about a little bit about pre-existing comorbidities. We mentioned that the severity of the injuries obviously has an impact on the outcomes. But what else? What about physiological reserve and function? And I will devote some time of this lecture talking about frailty. And the major concept here is that chronological age at times does not relate well with your physiological age, and that not everybody over 65 years of age. In the case of Sting, who's rocking in Vegas this summer on his residence at the Caesar Palace, and just turned 70 years old, it's obviously in a much better shape than other counterparts the same age. And so the concept of frailty, it's this phenotype of multi-system impairment and increased vulnerability, which is associated with a high risk of adverse health outcomes that are not completely explained by age. But if you look through the literature, there will be many other definitions of frailty and many other ways to characterize frailty that are different. I think this is a good example. And the other fact on this regard is that, for example, the frailty phenotype is very good for preoperative evaluation of frailty, and it might not be as good for other scenarios, whereas other factors might be more related to medical condition or complications from medical disease and so forth. So it's at times difficult to really put your finger and define what's the best definition of frailty. But I'd like to say that frailty at the end is basically the lack of physiological response or the physiological activity across multiple organ systems. And when you have, the normal aging individual, might have in time of age a longer life before they come into the frailty. But if you have an accelerated aging process due to coexistent disease or other factors, the patient will be into frailty and disability on an earlier stage of their life. Or if an event like surgery or trauma or medical condition like myocardial infarction or stroke happen, the patient with normal aging will rebound better than the patients that have accelerated aging and are on this window of frailty already. And if you want to keep it even more simple, basically frailty in a way you can say this ability that you have or losing the ability to rebound after something happens, and using this basketball as a visual for that phenomenon. So what's the impact of frailty in critical ill patients? So on this study in the American Journal of Respiratory and Critical Care Medicine in 2016, they had about 1,000 patients who had a median age of 62, and they have a frailty score about 3 on a scale of 3 to 5. And what they demonstrated that, the greater this frailty score, it was associated with a greater mortality and greater odds of disability in activities of daily living at 3 months. So, and I think they also raised an important point on this paper, which is a lot of times we concentrate on mortality, but also quality of life is important. So looking at disability or the inability of patients to return to their prior residence is also a factor to consider when we look at trauma or critical illness on the older adults. more specific to trauma outcomes. So this is a paper they looked initially prospective study at a level 1 trauma center. They will calculate in this frailty index using 50 pre-admission variables, and they found that being frail was a significant predictor of unfavorable outcome. And they defined that as discharge to a skilled nursing facility, again, quality of life being an important factor, or death. And when they look at the data 2 years later, or 2 years into the study, they figure out that about 44% of the total geriatric trauma population was frail, that frailty was an independent predictor of both in-hospital complications and adverse discharge disposition. There was a better predictor of complications and adverse discharge than both age and the injury severity scores. So that, and again, chronological age has nothing to do, and maybe, being not frail, you can rebound better for the same injury when compared with somebody that's frail. They also found that complications like UTI and pneumonia were more common from frailty, older patients, and I suggested that maybe was an indication for protocol-driven management on these patients. And I'll make emphasis on this protocol-driven or a specific pathway for those older patients later on the lecture. Another paper from the American College of Surgeons journal, they have this 15-variable trauma-specific frailty index. And again, they look at that, and there's a predictor of unfavorable discharge or disposition. Now, at least from the practical perspective, when you're not engaged in the study and you have to do extensive frailty evaluation, it's something else that we could do or have handy to help us predict whether this patient is frail or not. And most of our trauma patients will get an abdominal CT scan as part of their workup. So in this paper, they look at 450 patients, and they look at the CT scan, and they look at about 167 of them had sarcopenia, 48 of them had osteopenia, and about 161 didn't have any indication of that. And what they found is that on patients that have osteopenia or sarcopenia or both, they had a higher risk 1-year mortality after trauma. So they suggest that abdominal pelvic CT scan and trauma center for other radiological indications might also serve to try to diagnose frailty and also have a predictor of potential complications or poor outcomes and the potential to have targeted intervention for these patients. Similar paper in about almost 1,200 patients, evenly distributed between male and female. They looked at the psoas area at the level of third lumbar vertebra by CT scan, and they found by the definition of the measurements that are here on the slide that about sarcopenia was found in about 145 males and 145 females, and sarcopenia was associated with high risk of hospital mortality, a high risk of discharge to less favorable destinations, and also a longer length of stay. So, if you don't have a specific scoring for frailty, or you're working on it, or it's too time consuming, a CT scan might give you indication of sarcopenia or osteopenia, and maybe you can make your determination of frailty that way. Recently, there's some work about using ultrasound, and in anesthesia, we are becoming really familiar with point-of-care ultrasound. However, so far, in this first paper for the American Journal of Emergency Medicine, they say, well, the CFS9, which is a frailty score, has a great predictive value in ruling out frailty, but the ultrasounds on the biceps, on the quadriceps, only have a modest correlation with that score. This other paper also looked at measurement of sarcopenia. An older patient had moderate associations with frailty, falls, and subsequent hospitalizations. And another paper concluded that frailty is a multifactorial, and then using ultrasound only for diagnosis of this condition might not be the best practice. So ultrasound could be an option in the future, but more studies need to be done. So in the last 10 minutes of this talk, I want to concentrate on the strategies that we might want to have for improvement of the geriatric trauma care. So one is the geriatric trauma patients are slightly different, and there are some physiological changes of frailty that are related to this. So we can see, if we do the ABCD evaluation of the geriatric patient, they tend to be macroglossic, they tend to have high risk of aspiration, they have decreased neck mobility, they might have a difficult airway due to arthritic process on their neck, their chest wall is rigid, they have increases in BQ mismatch respiratory-wise, so they're more susceptible to hypoxemia. They tend to have diastolic dysfunction, so they're very sensitive to fluid shifts. They tend to have arrhythmias, especially atrial fibrillation will cause problems with the cardiac output, as we all know. They have poor response to catecholamines. We might have given them also beta blockers, which further decrease the catecholamine response on these patients. They might be anticoagulants. And, years ago was aspirin and Coumadin, and now we know we have all these new anticoagulants that we need to know how to manage. They might tend to have, head injuries, and they will have a tendency to, have head bleeds on a higher incidence than younger counterparts, and also they tend to be very susceptible to hypothermia. So when you're talking about them, and you think about these A, B, C, D, E, and I added F, and then we talk about frailty already, which is important to consider. Consider early intubation, make sure that they are monitored properly and early with a pulse oximetry and providing with supplemental oxygen. Consider that they might have deceiving normal vital signs, just because what I talk about the cardiovascular system, they might potentially need a surgical intervention, and keeping them warm is of paramount importance. So what you triage, and the other is that, normally we will triage a trauma patient by mechanism of injury and vital signs, but this might not be sufficient in geriatric trauma patients. And despite it, on this paper for the Journal of Trauma, despite having high injury severity scores, patients age of 70 and older often have normal vital signs. And there is a tendency to under triage elderly trauma patients. So on this retrospective analysis from the Maryland Ambulance trauma patient information, they looked at the patients over 65 years old tend to be under triage when compared with younger ones. But he also noticed that this tendency started when the patients were 50 years of age, and then also there was a second spike before at the age of 70. So it seems to be that we really need to think differently when we are looking at a trauma patient on the field, an older trauma patient on the field, and be more aggressive or how we triage them or have a different triage criteria. Similar paper here in about 4,500 patients older than 65 years age. They under triage them on the field, and they tend to have ISS more than 15, and there was no trauma activation on arrival to the hospital, and about 15% of those patients had that happen to them. And when that happened, the mortality was significant. So we might want to have a specific trauma criteria for the older adults. So be more aggressive in terms of the Glasgow Coma score, if it's less than 14, or if we suspect or know about a traumatic brain injury, if the systolic blood pressure is less than 100, if there is any fall from any height, and if they have multiple body system injuries, or if they were struck by a mobile vehicle, this might be an indication to bring them to a trauma center and not to a regular ED, just because we might be under triaging them, and this is all related somehow to those physiological changes that I talked before. So issue 1 found that geriatric specific trauma criteria had a higher sensitivity in identifying geriatric trauma patients who required triage to a trauma center. An X-ray hold for 70 years old for full trauma team activation, regardless of the mechanism of injuries or vital signs, also improved outcomes and was cost effective and related to a lower rate of over triage. So again, we need to think differently when triaging these patients on the field or even on arrival to the hospital. Another important factor is on trauma is volume. So on this paper, on a single state retrospective cohort study, they noticed that trauma centers with a larger volume of geriatric patients have better outcomes in terms of mortality, complications, and mortality after the patient develops a complication. When centers that care for larger volume of younger non-geriatric patients will have higher odds of major complications with geriatric trauma patients. So experience of the team on managing these patients is important. And how could you do that is a good question. And there is already at least two ways that we could address that. One being having your emergency department obtain geriatric emergency department accreditation. And this is Ohio State, one of the first ones in 2018. Here in Boston, I'm aware of Tufts Medical Center to have the certification. Or you could also develop or create a division of geriatric emergency medicine, like here on the Harvard system, the Maginot Hospital has, who they only not only provide care for those patients, but it's also research ongoing on this area, which again, considering the fast-growing pace of the segment of the population and the higher incidence of trauma, is most important to develop. So in conclusions, there is an increase in the geriatric population and an increase in trauma on this group age. Our outcomes remain far from ideal, and these also have a significant clinical and economical impact. Also, when you are looking at these patients, well, age, coexisting disease, and the severity of injury has a role on their outcomes. Frailty could be a better indicator for prognosis and plan of care, including end-of-life issues, because it would be a concrete way or a strong point to talk to a family if the patient were to be progressing in the direction that without care could be happening. And finally, trauma outcomes can be improved by a specific geriatric trauma criteria, having a specific designated trauma centers for geriatric patients, and having geriatric specific protocols. I did not have the time of today to talk about orthogeriatrics, but it's a great example on how hip fractures could be managed in a protocolized way and improve outcomes on that patient population. So with that, I leave you, and I will have time for questions at the end of this panel. So thank you very much again for your attention to this lecture. Thank you very much for the to the organizers for the invitation, and I'll see what questions come up during the conclusion of the panel. Thank you very much.